All right, so treatment and why it matters. You can see in the image provided that there are three different segments on this graph. At the top, you have the untreated group. In the middle, you have the treatment group that has been delayed. And then in the bottom, you have people who start treatment early on in their disease course. The higher those groups equals a higher level of disability, as you can see on the side with the y-axis where it says disease progression. So we know, it has been shown study after study, that treating early protects people down the road. So we like to diagnose early, treat early, and get in there with the most effective therapy that is appropriate for a patient to help control disease, control inflammation, and give people a good level of protection for the future. So here we see a timeline of DMTs in multiple sclerosis. The first one became available in 1993, which was beta-seron. Epic, fireworks, celebration, a very monumental moment for MS and the community. However, it was limited in its efficacy, and over the next number of years, while more drugs became available, many of them were other forms of interferon, and another one was Copaxone or glutaramine acetate, which also had a limited amount of efficacy. The first highly effective therapy, which is still in use today, is Tysabri, which came out in 2004. This opened up another new era in MS. In 2010, we had the first oral pill for multiple sclerosis, followed by an additional one in 2012 and 2013. We had new IV therapies come out in the 2010s and additional treatments since. Now there's over 20 treatment options available for multiple sclerosis, many of them being highly effective. The way that I view this is like so. Here's the era of no treatments. Grumpy, nobody's happy. Then we get the age of injectables, which was great, but we had to keep encouraging people, keep doing it. You can go. I know the injection hurts or gives side effects, commonly not always, but it's what's available, so just keep going. Then we're used to being able to treat, but we have a limited number of options, so we kind of say, well, it was only one relapse. Maybe you should just stay on therapy and keep going, because we didn't have much else we could offer. Then we start getting more therapies available, many of them being highly effective, and we start thinking, maybe we should switch treatments. Enter the era of highly effective therapies, where we really start to think, what do we do with these? Do you have to wait? Can you pull the trigger right away? What are the potential long-term benefits or consequences of taking these treatments early on? Now we've progressed to an era of NEDA, or no evidence of disease activity. This is a very high goal, but something that we hope to achieve. What this represents is that somebody is free from relapses, they have no confirmed disability progression on their exam, they have no enhancing lesions on their MRIs, no new or enlarging lesions on their MRIs, and no worsening of brain atrophy. There's a diagram of this on the side of the page, but what we're going for is saying, is best as we can tell, any way and anywhere that we look, we are not seeing this disease progress or change. That's asking a lot of our disease-modifying therapies, but our patients are worth it. So it has been incredible to have these multiple highly effective therapies at our disposal to control the inflammatory parts of disease. However, there's a newer concept of PIRA, or progression, independent of relapse activity. So the inflammatory relapse activity might be controlled, but the degenerative progressive activity might still be ongoing. And somebody's disease might be getting worse, their disability may be progressing. What do we do about this? Because our therapies currently are not very good at treating it. We're working to develop new ways to identify patients who are experiencing this, ways to monitor it, and new ways to approach treatment of PIRA. You may have heard or read in the news of late about Epstein-Barr virus, or EBV. This is the virus that causes mononucleosis, which sometimes is called the kissing virus. It most commonly affects people in their teens and 20s and leads to extreme fatigue as well as other symptoms. Epstein-Barr virus is in the herpes families of viruses, which always live in you once you have them. They typically remain dormant, but they'll be with you as long as you live. Sometimes they might flare up and cause a new symptom, such as when you get a cold sore, that's a herpes virus, or shingles, that's a herpes virus. There was a study released last year of military and service members from the United States, and we found that while Epstein-Barr virus is very common throughout the general population, it seemed to be more or less ubiquitous in the patients and military providers who were diagnosed with multiple sclerosis. All but one of the people in this study had Epstein-Barr virus on their serology testing or blood testing. What this indicated is that Epstein-Barr virus may be an essential ingredient in the development of multiple sclerosis. There's lots of new ways that we're looking at this in terms of, can we create a vaccine against Epstein-Barr virus, and would that prevent MS from ever forming in the first place? Can we prevent treatments directed specifically at Epstein-Barr virus or cells that are infected with Epstein-Barr virus? There's some studies that are already underway, and we hope that this brings in yet another new era of treatment possibilities and options for patients living with MS.